It is exactly 35 minutes past the hour. Welcome back to Sunday Live here at Citizen Television. On to our topic of the evening, USAID.
Yes, I'm going to set the stage because we have with us in studio Dr. Ruth Libon-Marsha. She is a public health expert and she also heads the National Syndemic Disease Control Council. So we've been talking about a 90-day waiver that came into effect on February the 6th for HIV care and treatment, right? So what does it cover, this waiver? Because there's a lot of panic, of course. Will services, will medicines continue to be provided? So let's begin with what procurement remains in place. That is procurement of HIV drugs, test kits, viral load tests, lab equipment for clinical monitoring, TB prevention and treatment drugs, as well as medication for opportunistic infections. And then also as part of this 90-day waiver, there will be HIV testing for people diagnosed with TB, prevention of mother-to-child transmission and HIV-exposed infant testing, retesting during pregnancy and breastfeeding, as well as partner testing. Now, we also have as covered under the 90-day waiver, counseling and treatment literacy, adherence support, nutrition support for malnourished persons living with HIV, tracing and return to care, as well as post-exposure prophylaxis. Also, as part of this 90-day waiver, we'll have pre-exposure prophylaxis remain, and that is for pregnant and breastfeeding women, distribution of condoms to pregnant, breastfeeding women and their partners, as well as postnatal prophylaxis for high-risk infants. Then for TB screening for persons living with HIV, TB preventive therapy for persons living with HIV. This I learned today, cervical cancer and pre-cancer lesion treatment for women living with HIV. Related administrative expenses is also covered under the 90-day waiver. What is not covered, Jeff, is people other than pregnant breastfeeding women who may be at high risk of HIV infection or were previously initiated on a PrEP option cannot be offered PEPFAR-funded PrEP during this pause of U.S. foreign assistance or until further notice. So this, I suppose, is like sex workers, people in same-sex relationships, but I'm no expert. We have an expert. She'll explain.
She's in the house, Dr. Ruth.
Yes, she is in the building. What else is not covered is population-based HIV surveys, violence against children surveys, program-based HIV surveillance, community-led monitoring information systems, planning and targeting for the 2026 financial year.
Good Lord. Dr. Marsha, looks like this is a death sentence in a way.
Is it? I don't know. Let me ask you, is it?
Well, people are going to suffer.
I just want to probably answer that question differently. I think it's important for us to appreciate where we are today. And we are not where we were in 1990s, for example, when we got a PEPFAR program, 1994. So you have a couple of things working for us. One is that we have the capacity to actually predict and know where new infections are coming from. You've got an expertise. We also have institutions that we never had with the capacity that understand the global market, and that institution is KEMSA. If you look at across all the countries, I chair 35 countries across the world, and we were discussing this issue and the impact of some of these changes. And most countries don't have what we have. We have a functional supply chain institution that has access to global market, but also understand the entire procurement process. Then again, when you look at Kenya, how we do our products, for example, the antiretroviral drugs, we have one single pipeline, meaning that we do a forecasting and quantification and say next year we need drugs and commodities for testing and diagnostics worth 28 billion. Like, for example, that's what we had planned for this financial year. And in that forecasting, we also put for ourselves about 6 months what we call buffer. Now, what happens is that we look at the resources of funds. One is the government. The next one is the Global Fund for HIV, TB, and Malaria, and then PEPFAR. And when we speak about PEPFAR, we speak about PEPFAR and the affiliated agencies, CDC, USAID, USDOD, and PISCO. everybody who works for the PEFA program, from US government comes and coordinated under PEFA. So when they communicate what they're giving to us, especially in terms of commodities, they talk about it as one. So if you look at this particular financial year, what did we have committed under PEFA for HIV products? It's about, if you look at the dollar exchange rate, it gets near 10 billion Kenya shillings. And that's about 28% of what we needed. And then the other percentage was being covered by the Global Fund for HIV, TB, and malaria, and the other is the Kenya government. But even within that, we had a gap of about 12 billion Kenya shillings for the commodities to make sure that the supply chain is really what we need. When we talk about the supply chain for antiretroviral medicine, we look at it in different ways. We look at it from what does the patient have? They have a 90 days dose. What is at the facility? And then what is going to be at the central warehouse, which is now where we talk about Kenta. So we look at it that way. It's not just about drugs in one specific area. So what we do, we use data then to manage when each of these drug supply will be brought to the country. So for example, if government money was to bring the first consignment, which probably would be a 5-month supply, then we say government of Kenya money will be used between this, because also we don't bring all the drugs at once, we bring them first. So what the first time before the waiver came, the first thing we had to do is to look at what options we have. Because HIV is a global security challenge. It's not just health, it's a security issue, because there is no ARV for the poor and the rich. Yeah. It is one pot. So what we've had going for us is that ability to be able to say how we space these things out. However, I don't want to underestimate the impact of the US government in the HIV response, because we know that they have contributed significantly to where we are today.
Yeah, but Dr. Ari, the taps have been shut off. They've shut off the taps.
Did it, I'm curious, did it come as a shock to you?
Yeah.
So I think on the 1st of December, we launched something we called Operational Plan for Country Readiness pre and post 2030 on the AIDS response. And that thinking was around a roadmap that takes us to 2030. The shocker is when it comes too soon. You know, when you're planning to walk a journey with a partner slowly by slowly, it was too soon. Secondly, PEFA program gives us about 41,000 healthcare workers, 41,500. They spent about 17 billion. That's what they are estimated to spend in Kenya this financial year, just at the HIV program alone. And these included clinicians, included up to the level of auxiliary services. We include mentor mothers and peer educators. Now, when that is disrupted at once, it means that you wake up in the morning and you find yourself thinking about, how will I open facility X? And I want to say that it's not just easy to fold up things immediately and start reorganizing your own facilities, getting another clinical person to go to stand in for these people, because this is an investment. These are just not clinicians. These are highly technical services of people who have been trained over the years and who have very strong within building our system. One of the other elements that PEFA has been very strong on is the data systems. And they've supported us across the country to ensure that we get the data from the patient level to the lab level to the pharmacy, and bring it together. What the National Syndemic does, we put it together, and then we have visibility of what is happening in the country. So that was another area that, of course, would be a shocker for you if you woke up in the morning and realized that that tap would dry. But having said that, I must say that one thing that is going for us, which probably we may not see today, is the SHA. SHA and the affiliated health sector reforms are actually part of the sustainability agenda. They may not be perfect now, but if we lacked any form of any insurance system that allows for equity, that allows for the poor to pay for the rich to pay for the poor, or for the sick to be paid for by the healthy, then we would have no system or structure to see how we are going to get these programs as we moved on 2030. The other reform that was very useful for us was the reform of thinking about forming the primary healthcare networks, because that is where the Americans have been strong with us, giving non-governmental organizations. And by the way, we can't write them off, because the healthcare system, the way it's designed, you have to work government, you have to work private sector, you have to work with the communities. For the HIV response, minus people living with HIV, you have a shallow response. You know, today when someone gets diagnosed with HIV, it's not just that like any other disease, I must tell you. It becomes a personal crisis. Sometimes you ask someone, who do you want to call in your family? They don't have anyone to call. They just go blank. And so what we've done over the years is to create another kind of people. These are people living with HIV. Those who are diagnosed before this new person, and we put them and they are supported so that when we say, they tell someone, oh, by the way, I was there one day. And when I was diagnosed, I spoke to so-and-so and life became better. So that is another industry there that they've helped us.
Dr. Tari, real quick, I don't want to say you are in denial right now, but what happens after 90 days?
So this is where I was coming to get to. So right now, what we have is what we call disruption. And it's disruption, it's big. For example, the waiver you've seen, it's selecting some population. From the 41,000 staff that were with us, we now anticipate probably those who are working will be about 12%, based on what you can see the program has hived off. Most importantly is the impact on prevention. As you can see, the entire prevention program is off the table for 90 days. Someone has to pick that up. Yeah. We also must admit that although people may think that some of these communities, we've been working with sex workers, men who have sex with men, people who inject drugs. If we let it go today, it will be disastrous for the country. So even within that 90 days, we have to think about who is this person who is going to provide opiate substitution therapy in a clinic, because that is not funded anymore. Are we going to let the communities that are at high risk to go away from the system, or are we going to integrate them slowly and with an understanding? Because once they get stigmatized, they go underground. You lose your sex workers today, they are not on antiretroviral treatment, then you have another disaster. So I want to say it's big in that way, because you have the entire system disrupted. So then what is the opportunity right now? It is the opportunity for us now to quickly put our house together. Because if we don't come and cooperate between citizen and government, that we decide that as much as it's the government that is actually trying to help us look at this, even at the individual level, we begin to see prevention as a personal agenda. That is one thing the citizen must help us to do. Then on the other side, the government is to quickly reorganize ourselves, to begin to see how do we structure this health system that has been supported over the years by someone, giving us all these necessary inputs that we required, technology that was fantastic, you know, technical people that we cannot afford to lose the entire 41,000. We must begin to think about, these are experts. They are Kenyans, by the way. They are professors, they are scientists, they are epidemiologists. We have to start thinking about what can we probably wait for this 19th of April with. Can we wait for them with something on the table and say, maybe we need a couple of them? And we were anticipating to see, like, if we put about 3.9 billion on the table, we can see how many of them can be quickly given maybe short-term contracts to stay in the health sector. So it's big. I don't want to deny. But what I can say is that because of the way the supply chain has been organized, we don't anticipate that we'll come to a place where we say there are no ARVs, because it's a public good. And this conversation we've had with the parliamentary committee we've been having, it's not like we're having it today. When these hit countries such as South Africa, you look at South Africa, 80% of the entire public good, which is the antiretrovirals and the medicines, are taken care of by the government. So when such a disruption happens, then they have smaller things to deal with. So for us, it's that we have to think about what must we do today. And the cabinet secretary did set up what we call a ministerial crisis management team. And the one question that we're putting by next week is that we are working like if we don't know what happens on the 19th. So we are going to be saying the first thing is business continuity. No. And the business continuity is saving lives. Jeff, you cannot afford to interrupt HIV treatment. No. Because even within a week, it would not just be impacting on the person, it would impact on the entire public health system. And
infections from 15 to 24, right?
That was a concern in the last report you released, World AIDS Day 2024.
Yes, and
how do you bring them down now?
Now, and that's why I was saying that, for example, one of the programs that has been dropped during these 90 days is the DREAMS. And it was, for example, focusing on these girls. If you look at Homa Bay County, where we have a high infections, Kisumu, we had this DREAMS program going where the girls could continuously get education. So we have to think differently. We have to think, what other infrastructure do we have? Jeff, we have to stop denying that we cannot stand on a moral pedestal right now and refuse to teach our children whichever sector we can do that business, including the education sector. We must reflect and say that if this is where education was happening, what happened to the gap? Because treatment is easy, it's a pill. But prevention is more difficult because you're working with people. We also must not forget sexual violence cases. And as you can see, one of the drug that we've been using even for key population, which is our sex workers, is what we're saying pre-exposure prophylaxis. So we kept them negative. Now there's a directive that you don't use any of their money to support any other population other than pregnant and breastfeeding women and their partners. Again, you must think about that. However, I must say that we don't even know how we can separate that. We don't have drugs labeled as PEPFAR. For us as Kenya, when you bring the drugs, you put them in the pot. And the money is what you come with, and we have one single supply chain. Even when the PEPFAR money is procured through meds, we still have a contract with Med under KEPSA, so we can take the drugs to the facility. So we are waiting to see how this unfolds, because I don't even see how even it's going to be possible to separate. Probably what may happen during the 90-day is that if they were to buy, currently we have about 149,000 people who are accessing PrEP. So maybe every year we have about 1.7 million pregnancies expected. And out of those who may need pre-exposure prophylaxis are not many. So maybe they would say, we reduce the number of the amount of money we're giving for pre-exposure prophylaxis. But I don't see us being able to say, this is American PrEP, I can't give this one, I can't, and the other one. So we wait, all of us, to see. I must also admit that some of this information also is just coming and unfolding every day. And that is why I think the best thing we've done is to say, let's remain on that crisis management, but take it as an opportunity. As a country, do you really want an election in the US to affect what happens here in Kenya?
Oh, you have no choice. I mean,
I'm curious. In October of last year, I think, they committed 43 billion under PEPFAR to run until September 2025. There must have been an operational plan in place. How does this affect that? So
one of the things that you can see with that money that was committed, it was supposed to end by 30th of September. So now we are midway. And because the financial year runs different from ours end in June, and that for PEPFAR was ending in September. So it means that whatever the commitment was is actually affecting 2 financial years, because it's affecting this year and also part of what we would have used for the first quarter of the next financial year. So we are also in a position where the one thing we can assure Kenyans is that the drugs will be there. And because we know for sure. Yeah.
Drugs will be there from where?
Because remember, as I said, the supply chain is not just currently with PEPFAR.
But they're not locally produced.
So let me just say this. The current supply chain, the way we've managed it, so we are going to call down some of those, and that's what we're trying to look into. Where the government money, if it was going to be taken into May, as we wait for April, we bring all those drugs, we call them down, we say from the manufacturer. In Kenya, we have, for example, Universal Corporation Limited, they produce the what we call first-line ARVs. And we must also look at that as the next place that we must go. Because then if we for example, had an assured market for Universal, and also you are paying them promptly, it means that we can have that first line where more than almost 1.2 million people living with HIV are depending on that drug. And if it's just produced in Kikuyu, Jeff, what would happen is that we don't have to have 9 months of wait period. It means that we can have the drugs and spend less. Yes. Secondly, I must say that one of the things that we've done as a sector in HIV, in the HIV sector, was actually to look at why is it that our local manufacturers are not really driven to go and be approved by the World Health Organization and approved by other country system to produce ARVs. And you find that there are incentives that we must also start looking at. And those things include fuel, include access to markets as government, how we are bringing other countries together, because most public goods have very low margin, profit margin. So when you start an industry to manufacture ARV, for example, here in Kenya, you have to be guaranteed of the Kenyan market so that you can break even. So if you're not guaranteed of Kenyan market, maybe you add a bit with Uganda, add with another country, then you find that people struggle. So we have about, I think, 2 companies that had started the process, but now Universal has already been producing ARVs, not just for Kenya, even for Central Africa region. So that is something going for us.
Mm-hmm. And on commodities, I read, because you've talked about PrEP and the exceptions that have been put in place, the vulnerable groups of sex workers, same sex, as well as drug users, right? But I also read that condoms, there's a provision for condoms, but for partners of pregnant and breastfeeding women.
And you're smiling like that.
No, she's nodding. I guess there's something she wants to add to that.
Yes. So I'm just saying that, which is truly what you're saying. The waiver is selecting populations that can benefit. But when you offer public service, the Constitution cannot allow you to start deciding, I'm giving this one, unless evidence shows you this is the most affected person. So in our case, for example, we know who needs condom. We know it's discordant couples, where one partner is living with HIV, another one is negative. We know are those sex workers that we must ensure they have condoms. We know those men who have sex with men, we must ensure that they are also having condoms. The injecting drug users, you also must ensure they're having condoms. And then, of course, those high-risk partners, people, especially in the general population, who don't categorize themselves as sex workers, yet they have what you call serial monogamy. Because serial monogamy may not be driven by money, but because you have multiple partners. And that's what is happening to our young people, where, for example, you get multiple partners, but at a time. So again, those are high-risk group. So I don't think we are going to sit as public health experts and begin to say, this commodity is needed by this person or that person. What you must do is what probably, Jeff, we're arriving at, is where else can you get this funding? And let me tell you something. The infrastructure industry in this country is holding so much money for the HIV response, because there is a legal framework that says for every infrastructure project you do, as part of what you give back about 1% for prevention, and HIV is part of that prevention of infections. So what we'll be looking at is that where is the new money, even within this particular crisis, that can now come in and be more systematic, because when you open up a road and you're making some form of investment, then you're also opening sexual networks. So that is why you say that you must give up that community by investing in a prevention program.
Dr. Ari, real quick, PEPFAR was a game changer for 30 years, almost 30 years, right? It was a game changer. And now it looks like...
That's a big gap to fill.
It's a huge gap to fill.
And I'm curious, right? So you talked about, is it 20% is funded
28.
by... You said
the commodities.
Yes.
No, the commodities, 28%.
28%
yes.
is funded by the US.
Yes.
So we're talking about the medication, the condoms, the test kits.
Yes.
28%.
Yes.
So like he says, that's a big,
it is
a
huge.
big gap.
It's huge. And that is why we are waiting for the 19th of April. But at the same time, not wait without options. What I must say is that I don't expect us to be able to take over the entire PEPFAR program. Yeah. And that is what we are not doing. Yeah. What we are doing now is to assess if we are today, the way the epidemic is, you have close to 1.4 million people living with HIV. You have 16,000 new HIV infections, most of them coming from young people. Okay. Today, where do you start?
Dr. Ari,
so what are you prioritizing?
Perhaps what's a best-case scenario, worst-case scenario?
Now, best-case scenario, we secure drugs, we secure diagnostics, and then we secure minimal kind of staffing within the facilities. So worst case scenario is in the event that we don't put our house together, which I don't see us not doing, because this is not the first time we are hearing about this, and sleep anywhere near of the commodities. That would be our worst scenario. If, for example, today we sleep on the job and something happens in the supply chain and we are not ready to ensure that every person who needs drugs has the drugs, that would be the worst scenario. But I think with the lessons that have been learned over time, because we were here again, we were in a crisis again when we had the shipment issue, remember?
Yeah.
Jeff, we went to the extent of saying, let's even divide the container we had at that time. So I believe Kenyans are very innovative. And we said, if you had a 90 days dose, by the time Parliament was saying you can go buy these other drugs, we said you can't have the 90 dose, you're going to have 30 days. And people were a little bit uncomfortable with that direction. But if you're managing a crisis, when you're managing a crisis, you look for localized solution. The only solution you cannot get to is to let people panic. Someone has to sit on the driver's seat. You cannot let people panic because there's no need for panicking. If at least you know where you're getting the drugs, and the only thing you're dealing is with money.
So at this point in time, people are getting their 90-day dose?
Yes.
Okay.
Dr. Ruth Laibon-Masha, good to see you. Good luck.
Thank you.
And thank you for speaking to us.
We'll talk to you on April the 20th.
Yes. Yes.
Thank you.
Day after the deadline. What do you say?
We'll call her.
Yes.
And we hope for the best. We really hope.
Always.
Maybe to just conclude, I must say that we look at every change of regime. If you look at from Bush time, we had PEPFAR program increasing. We had at the peak at Obama 1 year, then went down. Biden went down. Actually, Trump increased.
Round. Yes.
He increased the funding to Kenya. And Biden just reached a peak just below Obama. So you've seen the ups and downs. So what we are hoping for is not a zero. We are hoping that it's probably just something that takes us to where we want to go.
A little bump in the road.
Yes.
All right.
Thank you, Dr. Ori. Good to see you.
Thank you.
Asante sana. We're going to take a break right now. Come back. There's still some more news and sports as well.
Yep.
Keep tweeting. What are your thoughts? What are your comments on USAID and the way forward? At Queen Jeff.
At O'Burrows at Citizen TV Kenya.
The hashtag is Sunday Live. Sunday Live takes a break. We'll be back. It's also Citizen Planet as well.
Coming up.
Coming up.